we go on to question number 3. What is the most likely diagnosis and what is the primary defect in this condition? This is going to be a clue and then with a concept after it by knowing the primary defect. But you got to figure out the diagnosis first. So that's what we need to do. All right, so we read, 33-year-old woman presents for a routine checkup and mentions she's been experiencing increased thirst and frequent urination. Anytime someone has increased thirst and urination, number 1 is diabetes, because glucose and ketones pull water. Number 2 is hypercalcemia. Calcium makes your bladder contract a lot, so you have to drink a lot. And number 3 is diabetes insipidus. Her blood tests reveal hypernatremia and normal glucose levels. So normal glucose levels tells me it's not caused by diabetes, but hypernatremia goes with diabetes insipidus, so that's why my mind is leaning now. Water deprivation test shows no significant change in urine osmolality, but administration of desmopressin results in a significant increase in urine osmolality. Now, if you remember in endocrine lecture, you do the water deprivation test to separate nephrogenic diabetes insipidus from central diabetes insipidus. So if the person's osmolarity goes back to normal after desmopressin is given, that is central. If it doesn't, then it's nephrogenic. And in here, it says the administration of desmopressin results in a significant increase in urine osmolality, which tells me it's central diabetes insipidus. So now the question again is, what's most likely diagnosis? What was the primary defect in this condition? So we look for what we just discussed. E says hypothyroidism leading to altered water metabolism. The answer is no. D says SIADH due to excessive secretion of ADH. The answer is again is no. C says psychogenic polydipsia due to excessive fluid intake. No, that doesn't match our discussion. B says nephrogenic diabetes insipidus due to renal resistance to ADH. That's not what we're looking for. And then A says diabetes insipidus due to a deficiency in the secretion of ADH. That's the answer we're looking for because the renal receptors did work when you gave the person desmopressin. That's how you know it's not nephrogenic diabetes insipidus.